Hello, I'm Dr. Lewis Hassel from the University of Oklahoma Health Sciences Center, and I'm recording today's session on the first Monday of July, which traditionally in the United States is the first day of new residency training. And I thought it would be appropriate to provide some clues and tips as to how to learn pathology. And I think we'll do this in a couple of parts. Part one focused on how to learn pathology in anatomic pathology, but my career has spanned a number of different areas, and so I think we'll also talk about how to learn pathology from the standpoint of clinical pathology at a later point. So just to give you a little perspective on that background, I have been around for a few more years than perhaps many of you. And I'm now over 30 years since I finished or began my residency training. And I'm still learning. Now, what this means in terms of kind of historical perspective is that immunohistochemistry was not yet routine when I began training. We spent a lot of time on my first day, in fact, talking about histochemistry, but virtually nothing talking about immunohistochemistry. And yet now here we are in the next-gen sequencing era and also beginning to enter into the artificial intelligence and machine learning era. Now, over my career, I've practiced in a variety of different sites, both this mixed AP-CP private practice, as well as a setting where we even did nuclear medicine. I've directed a community blood bank. I've worked in a very high volume centralized cytology lab service and directed the same. I've worked in small rural hospital labs, as well as a regional reference laboratory, and practiced most recently in academic subspecialty pathology, currently focused quite heavily in GI and GYN pathology, but I've also done in academic some cytopathology and clinical pathology as well. Over the course of my career, I've managed to teach undergraduate students, medical students, technologists, residents, fellows, and a few of my peers as well. So I understand the process of education. I'm still engaged in it and still very interested in it. Now, a few years back, the Accreditation Council on Graduate Education for all physician specialties developed a paradigm of competencies in different domains that they felt would help to develop and provide a truly competent physician to practice, no matter the specialty. And these included domains like professionalism, patient care or procedural skills, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, as well as systems-based practice. Now, some of these terms are not immediately evident as to what they are, and I'm not going to spend a lot of time on this at this point. But suffice it to say that some practices and some time need to be devoted to each of these skill-developing areas. Of course, the majority of training is focused around medical knowledge and patient care skills, but learning how to fit that into a practice or a system, learning how to communicate that effectively, both with patients as well as peers, and how to act and behave as a professional still become very, very important. Now, of necessity in pathology, where we're covering so much medical knowledge, so much of disease, these areas of patient care and medical knowledge become much larger than the other areas. And so, not surprisingly, we tend to spend a lot of our time in these domains. And that's okay, because there is a lot to be gained there. But at the same time, we should not neglect the other areas. Those areas, however, are, I think, best learned through close observation, through mentorship, and through observation of others who are practicing in those fields. Now, additionally, my colleague Cindy McCloskey advocated for this approach as well to training, recognizing the progressive responsibility that is involved and the differing roles that a teacher or facilitator or mentor or whatever takes during different stages of that development. This is sort of the paradigm of entrustable professional responsibilities that tend to increase over time and experience. So it's natural that we don't expect the same things of a fresh out of school novice that we would out of a fourth or fifth year trainee. Now, unfortunately, a lot of our training is kind of like asking people to put together a puzzle without any knowledge of what the picture really looks like, or without much direction and guidance as to kind of where it might fit in the overall appraisal of things. So you can imagine that kind of dilemma. Picking up a piece of the puzzle might be totally meaningless, even though you can see what's on the puzzle piece and describe its contours and all of those sorts of things. But whether you're in Luang Prabang, where there actually currently are no pathologists and no pathway to figure out that, or someplace else, we really need a roadmap. And hopefully this will help you to begin to do that and begin to see that. Unlike my first day assigned to the skin and GYN rotations at Mass General, I got a stack of slides literally taller than my arm and no other instructions other than, oh, look them over and then be ready to sign them out. It was kind of a sink or swim approach, and I don't recommend that. I think we can do better. And hopefully now, 30 years later, we are doing better. We recognize, of course, however, that as far as this journey is, it is a long journey. And so what are the best first single steps to take? And that might easily be just recognizing that we need to look at a map. Or in some cases, we might use a different analogy and say, maybe we need to look at what kind of a building we're going to build. So let's look at a blueprint. And in pathology, there are blueprints of kind of what the building is supposed to look like and where it fits all, where things fit together. These often come out in the form of classification systems, textbooks, and so forth. Two of the notable ones here, one from the WHO or from the AFIP, have been very useful in terms of providing some images as to what goes in each of the rooms in this classification scheme for tumors or diseases of this particular organ or that particular organ. And so very naturally, by studying these kinds of blueprints to learn what the rooms or geographic divisions are, we can begin to at least get names associated with these rooms and perhaps see a few images, or even better yet, digital slide examples of what goes on the walls or what makes up the walls in those particular rooms. As we do so, we also learn some of the entrances and exits, or what some of the treatment plans, what some of the clinical presentations are for various disease entities that might present in each of these rooms and ask us to properly place them. Well, digital pathology is a great tool to enable us to provide some of that additional exposure to what goes in those rooms more effectively. And so beginning a few years ago, myself and a number of other colleagues have been providing these kinds of digital slide-based atlases or training materials to help individuals begin to properly categorize things. So, for example, this one on basic colon polyps comes together with some digital slide examples, as well as a video description of what's in the different categories of lower GI polyps. Now, I'll just mention in briefly that part of this is also what's being developed for the Open Pathology Education Network that I'm involved with, which is a great training tool in embryo for trainees, whether in a program or even without a program. Some sample other tutorials beyond those here for the lower GI polyps are some of these that we've developed over the years. And there are a number of other similar resources available on this YouTube playlist here that you can see. So before beginning an area, before beginning your trip through the GI tract, perhaps studying some of the tutorials about lower GI polyps or gastric biopsies or gastric polyps would be a very useful way to become acquainted with what the different classifications are in different schema that might come into play as you examine cases. Now, not everything has a great example, and sometimes you're still stuck with just looking at one or two pictures. But even then, oftentimes you would be surprised that if you do a little sleuthing through some of the online digital slide spaces and so forth, you'll be able to find digital slide examples that you can examine in their entirety for some of the less common entities. And these are some of the ones that I've used regularly and where you can readily and freely obtain them. I'll post some of the links to these and to the previous videos in the description of the video at the bottom. Now, an additional resource that I would recommend quite highly is that you consider joining the Digital Pathology Association. Here's the link. Membership there is free to trainees and students, as well as those from developing countries. And this allows you access to the Digital Anatomic Pathology Academy, which is a very rich source of online curated slides that can be a valuable training tool for you as well as others. In addition, there are many of the symposia or webinars or other sorts of things that are aimed directly at those new in practice or new trainees that are beginning to be exposed to pathology in the first way. Now, I am a believer that these digital resources make a difference. And so a couple of years ago, I did my very unscientific study looking at how two residents might interact with their case material that they were receiving in a randomized fashion when they were on my GI service. So Micro here, he got the cases and looked at them before sign out in the sort of the routine manner. And then he came and read whatever he could. And after a couple of months of just handling these cases in a randomized fashion, he was still only getting about 60% of lower GI polyps correctly categorized. So we did our intervention. We said, hey, here's our digital path tutorial on the classification of polyps. You'll look at 5 or 6 examples of each of the different types of polyps. You'll see a description, some annotations, and so forth. And then go and take a look at your digital slide exam, or excuse me, at your routine randomized cases that come through the door in whatever order happens to be assigned. And in fact, after just 2 weeks, residents on this type of a program were very frequently getting greater than 95% accuracy in terms of classification of lower GI polyps. Now, this is a simple example, but I think it illustrates the power of studying the map, seeing what's on the walls in those rooms through digital slide examples, and then being able later on to then take a new slide, a new example, and say, oh, this is a piece of the puzzle that goes in that room. Well, there are additional techniques that I think can accelerate and strengthen your learning beyond this example. One is to use chunked learning. So use every little time block that you've got, whether you're in the bathroom or whether you're riding on the bus or whether you're just trying to tune down at the end of the day, or maybe before you're waiting for a conference to begin. Look at some flashcards, look at a short video, or tune in on social media to some of the options that are out there. Twitter, Facebook groups, Kiko, other areas. YouTube have lots of very valuable pathology content that is oftentimes very well presented and goes beyond what you may find in your own program. Now, additionally, you have many mentors around to learn from. We oftentimes think that, a program is evaluated on the basis of the faculty. But in fact, the fellow residents within your program will be perhaps the most valuable resource for training that you will ever have. That was certainly true for me. I learned from my peers far more than I did from the famous faculty who were there on staff with me. Now, in addition to those that are within your program, there are many options to learn from those who are beyond your program, even without going to sit across the scope from them. Listening to them on webinars, following their YouTube channel, looking at their Twitter feed, those sorts of things are ways to learn from these people in ways that you might not have previously appreciated. In addition to these methods, there are other things to be aware of. There are regular online lectures provided through the Pathcast program or through the Virtual Grand Rounds program. I've mentioned the Digital Anatomic Pathology Academy, some of the slide sets that are out there, Twitter, Facebook, and so forth. These are also very good areas to learn from the best of the best. Now, one of the things that you do need to be aware of is that becoming a great anatomic pathologist is very much learning where to look to find the diagnosis. Now, this has been uncovered by doing eye motion studies of how experts versus novices examine slides. And so here you see this very abbreviated, truncated version of an expert pathologist evaluating some breast core biopsies. And after really just 3 primary fields, maybe a fourth, these areas with the numbers are the areas where their eyes dwelt. They've established the diagnosis. And when we look in contrast to what a new trainee or even a first or second year resident does, it's much more complicated than this. There's much more randomization to it. There's less, there's evidence that it's a less experienced and adept observer. So how do we get from being that new observer to being a pro? Well, one of the best ways is to watch how an expert does it, to sit across the scope from them or to watch them virtually, how they examine a slide, to see what they see and where they go. It's even better if they can talk about what they're seeing and what they're looking for and why they're going to where they're going. It can also be accomplished using annotations on a digital slide, because those will oftentimes identify areas where they see, this is something that would be helpful for me to make the diagnosis. More especially, I think, as you seek to train yourself, I think you have to discipline yourself to use the low power, low magnification image to guide where you're going to look and to see what looks different, what looks out of place, what looks slightly different color, to see those sorts of things first. Because really much of surgical pathology and perhaps even more of cytology can be accomplished at very low magnification. You can be provided very important clues to the diagnosis from that low magnification image. Now, this is particularly important to pathologists because most of the time, truth be told, we're operating using system 1. It's the FAST system. As my colleague said, if you don't know the diagnosis within the first 3 seconds of looking at that slide, you're probably never going to get the diagnosis. We operate from system 1. We know it's abnormal, and then we may refine how it's abnormal based on a few high magnification fields. But by and large, that low magnification image, that first flash of the slide onto the scope, is what's going to inform our diagnosis. So sometimes we'll use system 2, which means more slow and complex and so forth. But most of the time, we're using this very automatic, fast decision-making process to categorize things. The problem with that is that this can be error-prone. And that's particularly true if the data set on which we're making that fast assessment is faulty. Now, we've learned this from AI algorithms. As we train AI algorithms, there are a couple of ways to do it, through supervised or unsupervised learning. But we can think of what a trainee is doing as somewhat supervised learning. We're providing input data and then providing some classification to say, these are the apples, these are the bananas. Now, you can imagine, for example, that the limitation on this is the completeness or the comprehensiveness of that input data in terms of the spectrum of types of things that are going to be represented. So, for example, if you have no Fuji pears in this training data set to be excluded, they might easily be categorized as apples. Similarly, if you have no crab apples or no pink lady apples or whatever, those smaller fruits might be categorized as cherries or some other kind of fruit, rather than the apples to which they inherently belong. So this is particularly important as we deal with morphologic issues, to recognize that we need volume and we need a fully annotated data input set to be able to train our minds or our machine models to properly categorize things. Now, this is important because a lot of pathology is kind of like art as well. And so this rather famous painting, Edouard Manet's Déjeuner sur l'herbe, excuse my French there, is based on not something he saw, but on paintings, previous painters, this one from Titian from 300 years prior to Manet. Yet at the same time, we might say, well, is Picasso here doing the same thing? Is this the same scene that he's interpreting in a new fashion? And so is this tumor the same derivation as this tumor, just in a much more deconstructed or de-differentiated manner? And we might similarly look at this Hungarian painting, which was totally independent of Manet's work, without any knowledge of what had been going on there and say, wow, these have some striking similarities. Perhaps there are similar thought processes or similar social circumstances that are leading to this kind of painting. Well, I'm not intending to make you art historians, but to just simply point out that part of what a pathologist is doing is image processing for similarities, for differences, for patterns, for nuances that may define or refine something as original or related or derived from in various other ways. So keep that in mind and recognize that a lot of what you're doing is training your visual memory. You're encoding enough imprints of images and patterns and variations to be able to properly use that fast system of discrimination to make a diagnosis. Now, many times pathology can seem overwhelming, just like art can be. There's so many pictures, so many things. Well, in fact, sometimes we mistake the fact that our job is not so much, in some circumstances, to know everything, but to know what we don't know. And this was very well put by my colleague, Leilani Valdez, when I interviewed her, as she spoke about that stage in her residency training where she felt totally swamped and flummoxed. Fortunately, her father was a pathologist, and in talking to him, he said something very important. He said, "You have not understood. Your job as a pathologist is not to know everything, but to know what you don't know." And so she developed a system to help her do that and to learn what she didn't know. In doing so, she made herself a very safe pathologist, a very fruitful colleague, because she could tell many things with reliability based on her own experience, but she also knew where her limitations were and when she needed to get the other members of the team involved. She suggested this process: study a case, an unknown case, and then commit yourself to a diagnosis based on what you know and what you've seen. Then rank your certainty about that diagnosis on a 1 to 5 scale before you do anything else, before you share that case with another person. So 1 might be a case that I have no clue what this is. I would definitely show this to anybody and everybody who would help me. 2 is I'm pretty sure I don't know this case. I would be likely to show this and differentiate it from a few things. 3 would be, I sort of think I know what this is, but probably just to be sure, I would show it to somebody else. And 4 would be, I'm pretty sure I know what this is, and I might show it to somebody else for interest's sake, or if they were close by, but I could feel comfortable signing this out myself. And 5 is, I am dead sure that I know what this is. I don't need anybody else to tell me anything more about this particular diagnosis. So if you do that and make that level of commitment from 1 to 5 with each of your cases as you begin to evaluate unknown cases, and then begin to compare your level of certainty and what your diagnosis was with that final sign out, you'll begin to establish areas where you're capable, competent, and areas where you're still a risk. And that's the opportunity where you have the greatest ability to learn, is from those mistakes where you were dead sure it was this, and by golly, it turned out to be something else. That's the kind of case you don't want to have happen when you're practicing independently. So I suggest that method, and I think that's a great way of approaching your training with each individual unknown case. Now, I'd just like to echo some words from a mentor and a teacher who came and spoke with my medical school class, actually very early in our training. I believe it was our first year when he came and said, don't let the patient leave your office before you've learned what they came to teach you. He had a profound respect for the patient, a profound professional respect for what that patient could teach him, whether that was about medicine or whether it was about farming. But in any respect, in every respect, he sought to make sure that each case became a learning experience. No matter how trivial it may be, just an appendix or a gallbladder, there may yet be something there of enormous value to teach you. And you have to respect that in each and every patient. and each and every case and each and every slide. So to sort of summarize, study first the blueprint and the examples of what goes in each room. Use digital slides, as many as you can, to expand your range of understanding of the full spectrum of an entity, because you may not see 500 lung cancers in your residency training program, but you probably could find that many by searching various other sources. Test yourselves with unknowns and make note of your level of certainty or uncertainty. Then learn from your mistakes and learn something from each and every case. You need to find ways to see lots of training cases. You need to use your time well, time blocks of all sizes. You need to find mentors within your program, beyond, now and previously, as well as in the future. And learn from your peers and teach your peers, because as you teach about your cases, you learn them even better. You'll become a better pathologist. Finally, don't be discouraged that the journey's so long. Malcolm Gladwell talked about the 10,000-hour rule and reminded us that for any complex field, whether it's playing chess or being a neurosurgeon, especially for being a pathologist, we have this incredible problem of learning as much as we need to from them. And that is going to require time. You can't become good until you put in the time. And that's usually about 10,000 hours. Now, in a pathology training program, that might be 4 years, it might be 5 years, it might be longer, depending on how diligent you are. But suffice it to say that as you begin to approach that, and as you begin to practice with competency, with safety, with professionalism, you'll find that the journey has been enormously worthwhile. The vistas and the views ahead are remarkable. So enjoy the journey. So with that, I say thank you, and I'll look forward to talking to you again soon on another program as we talk about learning clinical pathology. Thanks so much for joining me.